Hello and welcome to the Strengthening Primary Care in Northern Rural and Remote Communities informational webinar. My name is Colleen Ferris, and I'm the Director of Innovations and Strategic Development here at Healthcare Excellence Canada. I would like to begin this event by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples from the beginning. In particular, I am calling in from Labelle, Quebec, which is the traditional unceded territory of the Algonquin and Anishinaabe people. The Algonquin and Anishinaabe peoples have lived on this land since time immemorial, and I recognize and deeply appreciate their historic and connection to this place, which I am grateful to call home. Before we get started, I want to recognize and thank the team here at Healthcare Excellence Canada, especially Jennifer Major, Senior Program Lead, and Megan Taylor, Program Lead, along with the support and guidance from our advisory committee in leading this work, including today's session. On the next slide, please note that this session is being recorded. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point using our chat box, and we encourage all of you to respond to any comments and questions in the chat as you wish as we go along. If you require technical assistance at any time during this webinar, please send a direct chat message to tech support soutien technique. We have a great lineup of speakers today who not only represent the depth and breadth of both lived experience and workforce perspectives in Canada's northern, rural, and remote communities, but also collaborated in the creation of this new program. Sandy Corporus, caregiver partner and advisory committee member, Melanie McKinnon, executive director of Ongamwizin, Dr. Stephanie Montesanti, associate professor at the University of Alberta, Dr. Jonathan Fitzsimon, medical lead for integrated virtual care. I invite all speakers to introduce themselves and share where they are calling in from today during their portion of today's session. I'll hand it over to my colleague, Jennifer Major, as mentioned, a member of the team responsible for leading this program, to walk us through what you'll hear in today's session. And as we just have Jen will come on in just a minute, but what we'll go through is just to share that information over the next hour will be provide information on the Strengthening Primary Care Program opportunity, including who should apply and how the program was developed, an example of the promising practice that will be shared through the program on HEC's webpage and during program activities. We'll also share information about an additional HEC program opportunity that may be of interest to you. And we'll just check if we've been able to get Jen online. Perfect. Over to you, Jen.
Hey, I am online, but I can't seem to turn my camera on. So we'll work on that. So I'm Jennifer Major, and I'm pleased to co-host today's session with Colleen. I'd like to acknowledge I'm calling in from Corner Brook, Newfoundland on traditional Mi'kmaq territory. So I think Colleen's reviewed what we're going to hear in today's session. What I'll add is that, as Colleen mentioned a little bit earlier, share your questions and comments in the chat. We're likely not going to be able to answer all questions today, but we'll plan to send out a follow-up email to everyone who registered for today's event, and we'll be certain to answer any questions that you had through that email. So just checking my camera again to see if there we are. Okay, so next slide. So this slide shows you the goal of the program. So the goal of the Strengthening Primary Care Program, really this opportunity is to improve access to safe, including culturally safe, team-based primary care closer to home in northern, rural, and remote settings. So first, just a few definitions. So, primary care, we're considering to be the first place people go for healthcare services. So, it'll include for non emergent diagnosis or treatment of a health issue, illness, or injury. Example providers can include family doctors, nurse practitioners, physician assistants, pharmacists, dietitians, social workers, or therapists. And primary care draws on the expertise of many providers working together. In terms of rural and remote communities have limited or no year-round access and are reachable by air ferries, remote railways, seasonal roads, or unreliable gravel roads. And rural communities are outside of commuting zones of larger urban centers and usually have populations of less than 10,000. So if you have questions about those definitions we're using, feel free to pop them in the chat. So why is this a new program focus for Healthcare Excellence Canada? While improving access to primary care closer to home when and where people need it has been long recognized as a solution for reducing health disparities and improving health outcomes. Research has demonstrated, for example, that greater access to primary care can facilitate early diagnosis. It can lower mortality and improve physical, mental, emotional, and social outcomes. So the program will also focus specifically on northern, rural, and remote communities for a few reasons. So we know that people who live in northern, rural, and remote communities often experience poor access to primary care compared to people who live in urban communities due to unique challenges, including fewer available services and providers, a preference to stay in community and avoid medical transfer, or transportation costs and challenges to even access primary care. As well, we know that providers who work in northern, rural, and remote communities face different challenges compared to those providers who work in urban settings, including often less access to networks of care, broader scopes of practice, travel challenges, and increased responsibilities to help patients and families navigate services and medical transfers. So the program will bring together providers and organizations who help deliver primary care in northern rural remote communities. They'll work together to advance unique goals for improving access to team-based primary care, while also sharing and learning with other primary care providers and organizations from across Canada. So it's really an excellent opportunity for an all teach, all learn setup. The program does recognize the strengths that local leadership and communities bring to support healthcare and aims to shed a light on those strengths and provide tailored supports to respond to the needs of local communities and providers. We've created this program, as Colleen mentioned, in collaboration with an advisory committee who have a breadth and depth of both lived and workforce perspectives in Canada's rural and remote communities. So our first speaker, Sandy, has lived and worked in a rural community in Manitoba for most of her life. So I'm going to invite you, Sandy, to introduce yourself and share an example of an experience when you saw that team-based primary care in your community improved care outcomes for a patient. So Sandy, I'll turn it over to you.
Thank you, Jennifer. I just want to make sure everybody can hear me okay. My name is Sandy Karopis. I live and work in the Interlake Regional Health Authority, and most recently, for the last 25 plus years, I've worked on the community of Broken Head Ojibwe Health First Nations. I've had many wonderful roles throughout my career, but on a more personal basis, my best role is the one I'm in now, being a grandmother. As my mom used to say to me, if I knew it was going to be this great, I would have skipped everything else. I live in Manitoba, where for the first 25 years, I worked as a nurse educator throughout the Interlake Regional Health Authority. I'm still actively working in Broken Head First Nations Health for more than 20 plus years. In my role as the manager for the Indigenous Health Program with the Interlake Regional Health Authority, I worked with the Regional Primary Care Manager, Paul Bernard. Paul had the same vision as the Health Care Excellence Canada for inclusion and smooth transition from a hospital to home and home to hospital. The goal to provide clients, communities, and regional staff with the communication, information, care they needed, and everyone working better together. In that role, I help support providers and patients living in several remote and rural communities in the area. I've seen firsthand how the lack of access to a team-based care can lead to poorer care and patient outcomes. But today, I will share an example of when team-based primary care improves patients' cares and outcomes. As context, I want to emphasize how important it is for providers to know the communities in which their patients live. Each community, each area, each leadership, each patient is individual, and they work differently, and we need to know that. This includes knowing that what types of medical supplies are available to people who live there, as well as access to support services, including home care supports. Most of the rural communities do not have access to the primary care of or home care supports 24 hours, or medical supplies such as specialized wound care supplies. Many have the basics and limited hours for visits. I was involved in an initiative where we had a community-based nurse take part in the discharge planning rounds for patients. So they would virtually connect with the hospitals every Tuesday or Wednesday morning when there was discharge rounds. The community-based nurse knew the types of medical supports and supplies that were not available to patients, as well as what was available, or whether community client supports ability to get into their homes, or for some, if they even had running water or not. This information is very important to consider during discharge planning. Knowing the difference between a health center and a nursing station is also very important. For wound care, it's important for the discharge planning team to assess whether the patient and the care partners will have access to medical supplies to care for wounds at home to avoid infection. It's also important for the discharge planning team to equip the patient and caregivers with the information they need to care for the wounds safely from home, to ensure the right home care support follow-up is arranged. I saw firsthand how including a community-based nurse as part of the discharge planning team brought that important community understanding and partnership into the care and improved outcomes for patients. Patients went home with supplies needed to care for the wounds safely at home and were less likely to need to return to the emergency room or hospital with an infection. I've seen the opposite as well, where the community understanding was not brought in from a care team member, and the patient was not sent home with the right supports to care for wounds following discharge. And that patient ends up back in the hospital with an infection from the wound. Too many hospital admissions, failed discharge happen, and this can be avoided by better communication. The idea of having a community-based nurse home care part of the discharge planning from the hospital was wonderful, and the outcomes were so much more positive. The Healthcare Excellent Committee program that will support providers involved in delivering primary care to improve team-based primary care based on needs of the community has a huge potential to improve patient experiences and outcomes. I've seen it, and I'm very proud of what was going on in the Interlake. To do this throughout Canada would be so wonderful. And for the clients alone, just such a wonderful experience, and less hospital time and transportation, etc. Thank you. I'm going to send you back to Jennifer now.
Sandy, thank you so much for sharing that. It's such a great example that demonstrates the importance of providing team-based primary care that really responds to and reflects the unique resources, needs, circumstances of communities, which can then lead to better patient outcomes and provider outcomes and experiences as well. So that's really excellent. And I think, as Sandy mentioned, part of the great thing about this program is that everyone who participates will be able to learn about promising practices that are working elsewhere, so they consider whether or not that's a fit for their communities and providers. So thank you again, Sandy. So who should apply? So this slide lays out that information. Overall, who should apply include groups involved in delivering team-based primary care in northern, rural, or remote communities. So we do encourage applications from multiple organizations from the same health region, province, or territory, or even across health regions, provinces, and territories, so that they can apply together so their efforts to adopt or strengthen a promising practice to improve access to team-based primary care can reach more people. So an applicant, for example, could include a regional or Indigenous-led health authority in partnership with several primary care clinics or nursing stations, or an Indigenous, provincial, or territorial health department in partnership with community-based organizations involved in delivery of primary care, who all want to work together to strengthen a practice to improve access to team-based care. So example program benefits, they include seed funding of up to $50,000 per team. So the call for applications is available on HEC's website now. I'll ask my colleague to pop that link into the chat, but that call for applications includes a description of eligible and ineligible expenses. Eligible expenses include, for example, salary replacement costs to allow providers to participate in the program, or funds to hire additional staff to backfill jobs of program participants. They also include virtual and in-person networking, coaching, and learning events, including likely an in-person event in March that will convene all teams from across Canada, and also support to adopt and strengthen a promising practice to meet the needs of communities to improve access to safe, including culturally safe, team-based primary care. In addition, participating teams will be supported to measure and evaluate the impact of the promising practice to improve access to care that they'll focus on implementing or advancing during the program, to assess impacts on outcomes such as patient and provider experience, increased volume of team-based care delivered in community, reductions in avoidable emergency department visits, and in other ways based on the impacts that participating teams want to achieve. So on the next slide, this reviews some information that you'll find in the call for applications. So first, you can go to HEC's website and read through the full call for applications. That contains detailed information about the opportunity, the benefits, eligibility, requirements, and other information that'll inform your decision to express interest to participate. The application form is also available on the website and will remain open until September 25th. I'm not sure, Sheena, if there's more information in the slide. Perfect. That's great. So that's the first one. If we go to the second step, we also really want to encourage you to contact HEC at the website, at the email address that's on the slide. We want you to let us know if you're interested to participate, and then we'll explore scheduling a call with you so that we can help you with the application process. So that can include, for example, helping assess eligibility and then kind of working with you to figure out what the team could look like so that you can reach the most amount of people. On the third step, so you'd have to complete and submit the application to that same email address by September 25th. Applications can be submitted in English or French, and we'll notify applicants of the outcome of their applications by the end of October 2023, and program activities would start in November. So the next slide gives you some of the program outcomes. So these have been mentioned throughout already today's event, but just to give a little bit of a snapshot of the program timeline and outcomes. So following HEC's support to complete an application to participate throughout, which happens between starting today and by September 25th, an invitation for successful applicants to join the program will be issued in October. And then, as I mentioned previously, program activities will begin in November 2023. And those activities run until September 2024. So that's the duration of the program, essentially, November 2023 to September 2024. The program benefits will support program participants to ultimately improve access to safe, including culturally safe, team-based primary care closer to home. And at the end of the program, Participants will achieve outcomes including new and further developed relationships and partnerships. They'll learn more about promising practices. We'll work with those teams to actually write up the promising practice they're focusing on that is intended to improve access to primary care, so we can post that on our website and share it with others. And also, and very critically, support to adopt or strengthen and evaluate that promising practice that aims to improve access to primary care. So those are some of the benefits. So on the next slide, team selection considerations. So together with an advisory committee and through a review process to identify a diverse group of participating teams, we will review and select the program participants to join the program. We're seeking to include up to 20 teams with diverse geographical representation, including teams led by First Nations, Inuit, and Métis-led organizations. We are also welcoming groups at all stages of the improvement journey to apply. So if you've already identified a need, if you've conceptualized a solution or a promising practice, or if you already have initiated implementation and already are achieving impacts that are very positive, we still want you to consider applying for the program, but we'll certainly look to include a range of teams that are at different stages, including teams that want to strengthen something that's working well and already showing positive results. Additional selection considerations are listed on the slide and include identified community need to encourage inclusion of under-resourced teams, that you have a defined population and a clear sense of the potential patient reach, where there's a potential to really benefit the diverse populations that your organization provides care for. Program team composition that is representative of the communities that are served. So in the application that you'll find on our website, the questions kind of follow what those team selection considerations are. So you'll see that we'll be asking you questions about what you see on the slide there. And then I guess the final thing I'll say in terms of team selection consideration is really a commitment and a demonstrated commitment that you'll communicate in your application to collaborate with diverse local stakeholders. So we want to encourage multiple organizations to apply together so their efforts to adopt or strengthen a promising practice can reach more people. And we are really looking forward to helping you think through some of the questions and considerations that are on this slide. So again, encourage you to reach out, express interest, and we'll set up a conversation. So next slide. And I know there's lots of questions coming in the chat. Keep them coming, and we'll be able to respond, if not today, via that follow-up email. So what do participating teams commit to if they sign up for and are successful for this program? So again, you'll find more detailed information about the program requirements and commitments in that call for applications that's available on on the HEC website now. But some of the program commitments include signing a collaboration agreement that outlines the program commitments, such as the funding distribution and how you need to report on how that funding is spent to support your efforts in the program. You'll also commit to participating in the program activities. So we want other organizations who are participating to learn from the strategies that you're implementing, and we hope that the challenges that you may have experienced and solved can be shared with the other teams as well. So we will do, for example, quarterly, about 1 hour coaching calls with each individual team so that we can better understand your tailored needs. And we'll host regular 1 hour webinars, approximately one every few months. And I mentioned earlier, I believe, but we are hopefully going to have an in-person workshop in March of 2024, where we'll invite all teams to send representatives of your team. So that'll be really exciting. And then, of course, the other thing that I've mentioned multiple times is really a commitment that you're going to work with your team to adopt and or strengthen and evaluate a promising practice to improve access to team-based primary care. So you'll see in the application that we will ask you to specify the promising practice that will be the focus of your work during this program. As part of your work to do that and adopt and strengthen and evaluate that practice, we will ask you and support you to complete an implementation and evaluation plan. So that document will really give us information that we can understand and share with other participating teams that describe the strategies you're going to use and the progress that you make toward your goals. And that implementation and evaluation plan will be due to HEC at the end of the program in September of 2024. And again, we'll provide you with support that you need to create it. For example, there'd be protected time at that in-person March workshop where we'd provide you with lots of support to work on that protected time. The other thing, and I think I may have mentioned, we are really excited to collaborate with all participating teams to help you develop a summary of the promising practice that you are going to implement through participation so that we can share that on HEC's website, and really that is meant to really support the promotion and sharing of innovations and promising practices so that we can help generate discussion with other organizations about how similar approaches could be adapted and applied elsewhere. I'm almost done this slide. So teams will also be required to identify, measure, and report impact of the promising practice on common indicators that we will be defining early on in the program. So common indicators may include reduced avoidable emergency department visits, access, improved access or greater volume of team-based care in the community, improved experiences of care for patients, and improved experience of care for providers. So one way we'll support this step is by potentially pairing each participating team with an evaluation coach, if that will help meet the needs of the teams related to identifying, measuring, and reporting the impacts. And finally, all teams will have to complete progress reporting. That's not time intensive, a few hours at various time points, including 2 brief surveys and 1 final report to share information about learning outcomes, results, patient reach and sustainability. And again, information about that and all of the things I've just talked about can be found in the call for applications. So next I'm going to go to the program co-design. So we've mentioned this a little bit, but before I introduce some special guest speakers, this program has taken more than a year to develop in collaboration with an advisory committee who have a breadth and depth of both lived and workforce perspectives in Canada's rural and remote communities. So I'm going to pass it over to 2 such individuals who I think we'll see it on the screen at the same time, to invite them to introduce themselves and share their perspective on the value that the program can make for patients and providers who live and work in northern rural and remote communities. So Stephanie and Melanie will come on the screen now, and I'll first hand it over to Melanie, who will share a little bit of her perspective on this, and then we'll move to Stephanie.
Wonderful. Thank you, Jennifer. And it is a pleasure to be with you all today. As mentioned, I'm the executive director of Ongomazin, that is within the Rady Faculty of Health Sciences, the University of Manitoba. My background is nursing. I'm calling in from Treaty 1 territory in the home of the Métis Nation in St. Laurent, Manitoba. I'm originally from Treaty 5 territory, espoused to Cree Nation and Pimachigamac, which is kind of central northern Manitoba. I had the honor of working in many remote and northern communities throughout the course of my clinical career, but the last 18 or so years in health administration, and a dozen of that being at the University of Manitoba, has been quite challenging, but also very gratifying in the work that we do to serve our northern and remote communities. So Ongomazin is an Anishinaabe word that means clearing a path for the generation to come. It also has another meaning by our language speakers, which tells us to be careful, to be cautious in the work that we do. So we carry that principle with us when we are working with communities and trying to design or co-design programs with them. And I've had the honor to work with Healthcare Excellence Canada this past year, as mentioned, on the advisory committee, and it certainly has been a privilege, and I've learned a lot, and I really appreciate the opportunity to be engaged in this national network. But I think what I really appreciate most is the supports, as Jennifer mentioned, around knowledge mobilization. I think we all do incredible work in our respective organizations across this country, but I don't know if we have an opportunity to share what we do and how we did it, so we can all either adopt or adapt those best practices and learn from each other. So this past year, I was able to present on the work that we did around onboarding physician assistants into Northern Manitoba. We currently serve 30 out of 63 First Nation communities with physician and physician specialist services, and we've recently onboarded physician assistants. And that work continues to evolve and to grow, and we've learned many, many lessons. But sharing some of those best practices around remote supervision, for example, with the regulatory bodies, and how we did that, and how we worked with the College of Physicians and Surgeons to create a new classification that allows for that adaptability of another scope of practice to be introduced in a new clinical environment. And we're happy to share that that continues to be on HEC's website. We also introduced the concept of flexible physician employment models and what that looks like, to the point where our retention has gone from an average of 6 months to an average of 6 years in the past decade. And so happy to share those best practices as well from a workforce and operation perspective. The support that we received from HEC is, in doing all of this great work together, sometimes we're not that great at putting pen to paper and mobilizing that knowledge. And so they are absolutely there in real time and all the time that we need them. And I really appreciate the evaluation support and the coaching because, when we're doing clinical interventions, sometimes we don't have either the workforce or the expertise to be able to be surrounded in that way, so that we could share that best practice with our colleagues across the country and perhaps even internationally. So I really do hope that you consider this opportunity. I'm really happy to be a part of this work, and we'll continue to be as helpful as we possibly can. So thank you, Jennifer. Back to you.
Awesome. Thank you, Melanie. Really, we love that how you position that, and very much happy to shine a light on all the excellent things that are already happening out there, and hopefully help to strengthen them even further through this program. So Stephanie, would you like to share some of your reflections?
Absolutely. Thank you, Jennifer, for the invitation. Really honored to be a part of the Program Advisory Committee. Would like to first introduce myself. I'm joining you from my home here in Edmonton on Treaty 6 territory, which is a traditional meeting grounds, gathering place, and traveling route for the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. I'm born and raised in Toronto, Ontario, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, Chippewa, and Haudenosaunee and Wendat peoples. So have been living, working, playing in Alberta since 2013. And I've also had the opportunity to work in Northern Alberta in the regional municipality of Wood Buffalo, which includes a number of small First Nation communities, which are fly-in, fly-out communities on a number of projects, initiatives relating to primary care. And the other hat that I think really what brought me to this work with Healthcare Excellence Canada is my role as a policy lead for the Indigenous Primary Healthcare and Policy Research Network, which is a CIHR funded network. And just wanted to share a little bit of my thoughts in terms of what I see as the strengths relating to this program, and wanted to start off by saying that the program really it's wonderful to see how it is grounded in acknowledging evidence of what we know, in terms of what works, on promising practices that have improved access to team-based care elsewhere. And this program is not intended to be prescriptive. Applicants are invited and encouraged to strengthening a promising practice that exists in their communities. This can be a service or model of care that is grounded in local knowledge, supported by community engagement, and demonstrates outcomes on improved population health, patient experience, better access to care, reduction in hospitalizations, etc. And regardless of what promising practice the applicants select to advance during the program, a foundational principle of the program is to meet communities where they are at. No community is homogeneous, and all have unique resources, needs, and approaches. It also provides opportunities for Indigenous-led organizations to apply and be involved, as Melanie has mentioned. So there are notable advances that have been made in Indigenous community-based primary healthcare to strengthen primary care delivery in rural and remote or Indigenous communities. And there are pockets of innovations in primary care models led by Indigenous organizations across Canada, aimed at addressing many aspects of health and wellness. So I feel this program initiated by Healthcare Excellence Canada is so important because it builds on knowledge and evidence that exists. An example of a project that I had an opportunity to work on, not in Alberta, but out in Northern Ontario, was to improve community-based team care for type 2 diabetes in remote Indigenous communities. And it was really grounded in knowledge that was translated from leading work done in community health worker programs, operating various global health implementation contexts. And it was that knowledge that was used and adapted to implement a similar program focused on type 2 diabetes in that remote Indigenous community. So with that, I'll just hand it back to you, Jennifer, and thank you for the opportunity to share some of my thoughts today.
Thank you, Stephanie, and it's really been great, same as Melanie and Sandy, to have you as part of our advisory committee to continue to shape this, given your deep knowledge about in the space, and yeah, thankful for your guidance. So thank you so much for sharing. So I see a lot of comments, questions coming in the chat. We've been trying to keep up, so keep them coming, and we'll do our best to respond. I know people are asking about the email to send, so that I'll ask my colleague to pop that in where possible. Look forward to connecting to a lot of you. So on this slide, we show a little bit about promising practices we are going to mobilize, hopefully, and share through this program, as Melanie mentioned in her remarks. So through the program and on HEC's website, we will share promising practices that have improved access to team-based primary care to help generate discussion about how those approaches could be adapted and applied elsewhere. Some participating teams may decide throughout the course of the approximately year of the program that they would like to adapt one of those practices because it meets a need that exists in their communities. So you will see pictured on the slide, there's 5 that we have up on our program page right now, and we're working on 2 additional ones that will be coming soon, including that physician assistant model that Melanie mentioned, whereby they've gone from 1 physician assistant to 19 and drastically improved access to primary care in some northern remote rural communities in Manitoba, which is really fascinating. So have a look on our website for that. I'll say that program participants will have, throughout the duration of the program, an opportunity to interact with the leads of those promising practices during those regular webinars. If they suggest they'd like to have a coaching call involving some of them, we'll see if we can arrange that, for example. And of course, also during that in-person meeting in March, we'd like to have the leads of those practices there. And HEC will collaborate with participating teams to, as we mentioned earlier, co-develop summaries so that we can share all of yours on our website as well. So we're really excited about that and hope that people find that valuable. So I'm going to invite Dr. Jonathan Fitzsimon to share a little bit about integrated virtual care, which is one of the promising practices we have on our website now, which is a super amazing approach that's really improved access to team-based primary care in rural Ontario. So you'll find that summary on the HEC website. Jonathan has also expressed interest. We're very happy to hear to apply to this program to further spread and evaluate the integrated virtual care program to reach more people. So Jonathan, we'd be happy to hear from you about IVC, but also, why is this program valuable from your perspective? So Jonathan, welcome you to join us.
Thanks, Jennifer. Super amazing. Gosh, you're setting me up there. I better live up to that. So really fascinating hearing all the speakers so far, and I hope what I can do now is share a little bit, as Jennifer said, about the program that we've implemented and our experience with HEC on the previous program, which was based on virtual care, and how we benefited from that collaboration and partnership with HEC. So I'm the medical lead of this program. I'm a family doctor. It's based out of the Petawawa Centennial Family Health Center. The executive director of the Family Health Center, my colleague Judy Hill, is on this call as well. And Petawawa is in Renfrew County, which is the largest county in Ontario. You sort of head up the Ottawa Valley away from Ottawa, and about an hour later you enter Renfrew County, and then you keep going for another 7,500 square kilometers, and it's home to about 110,000 people. So Renfrew County does have a number of large towns that have community hospitals, 5 of those, and many smaller rural communities across the county. But we also have the worst attachment to primary care rate in the whole of Ontario, and we face a challenge that many communities do of recruiting family physicians. But like I say, the rates of 20% plus unattachment are very common across our county, and in some of those smaller communities are closer to 30%. And we don't have any walk-in centres or urgent care clinics. So there's a huge over-reliance on emergency departments, or the other sort of side of that spectrum where people just don't access healthcare, particularly primary care. And so we wanted to find a way that was a little outside of the box. We heard earlier Sandy talk about the importance of team-based care. And what we found is that we have a number of family health teams, government-funded family health teams, but we had this huge challenge of recruiting physicians in order to enroll the patients, which would then give them access not only to the family doctor, but to that team-based care. So what integrated virtual care does is we access a much larger pool of physicians, in fact, any physician across the whole of Ontario who works predominantly remotely. And so patients access their physician usually by virtual means, by phone or video or secure messaging. But they also have access to their local clinic and the whole family health team of allied health professionals and administrative staff there. So they get their comprehensive team-based care through a hybrid of in-person and virtual care from their physician, care from the allied health team, and also a hybrid of care from in-clinic compared to care at home. We have a close collaboration with our community paramedicine program, so we're also able to provide in-person care at home for more vulnerable housebound patients. And what we've been able to do through this program is firstly attract physicians who we would not otherwise be able to attract to our communities. And because of that, we've been able to enroll close to 3,000 patients who were previously unattached, who now have a named family doctor and access to team-based care through their local clinic. And all of the benefits of also being able to use a suite of digital equipment and virtual care opportunities, in the knowledge that their own family doctor is going to be there for them in the way that any sort of family doctor in a bricks and mortar clinic would be long term. So this really started at length 2 years ago. It grew out of a response to the pandemic and how we were starting to utilize more virtual care. And we partnered with HEC as an innovator in virtual care and improving access to primary care. And what we were able to do through that original program is firstly connect with like-minded people and like-minded organizations from across Canada, and firstly recognize that some of the problems we were having were problems being shared by others, which is actually quite reassuring in itself. But then to go the next useful step, which is to hear how other people have overcome some of those issues and some of the solutions that people are putting into place, to learn from those, and to share our own experience of how we'd overcome some problems, and perhaps others could learn from us. We were able to access expert advice that the HEC program brought to us. And that helped us do things like optimize the way we were delivering virtual care, both from our staff, clinicians and administrative staff perspective, but also how we could advise our patients to optimize their own experience of virtual care appointments with their doctor. We were able to access mentoring on how to best use our electronic medical record. So things like embedding video platforms, or using the embedded video platform in the EMR as opposed to a standalone program that ran alongside your EMR. These were mentoring and presentations that we accessed through the HEC program. And absolutely learned from that and implemented into the integrated virtual care program. We through that mentoring, through that sharing process, through that expert advice, we developed an enrollment process for new patients. I mentioned we have a really significant unattachment problem in our county, but we also have it's worse than that, because people have been unattached for so long. So the long-term unattached, people who haven't accessed primary care or had access to a family doctor for 10, 15 years or more, over twice the rate of the provincial average in our county. So literally just optimizing the way we enroll people and explain to them what a family health team is and how they're now going to access their doctor and how they book an appointment. Being able to do that digitally and virtually, whilst also putting in safeguards so that people could do it manually and in person. These were challenges for us. We didn't really know how to do that. And through this partnership and mentoring and collaboration, we were able to work through that problem and then share some of our successes with colleagues from across Canada. So I think that a lot of that could be described as networking, and I think absolutely that the program did give us that opportunity for networking with a much wider audience, and listen to other innovators and their innovations is very inspiring, and it keeps your spirits up when you're facing some of those challenges. But it comes also with the practical advice of how to solve some of the problems. And ironically, one of the mentors who gave us a lot of advice and helped us along the way has ended up working alongside us in our sister program. So there was a really direct connection that grew out of that program that we were involved in. So I feel glad that I'm able to sort of loop back to what Sandy was saying at the start about the importance of team-based care. We found that we needed an innovative, different solution to be able to offer that to our communities and to address the challenges that we face in rural Ontario. And by having that mentorship, the network, the partnership, the collaboration, and just the moral support of the HEC program, we really benefited from that. It helped us, and now we feel very much obliged to share our successes and to contribute to others that are going through the same program. And as Jennifer said, we may be a little bit further along that spectrum with our program, but we want to innovate further. We want to scale and spread. We want to offer this solution to more patients and potentially to more communities. And so we want to sort of stay on this journey with HEC because it's been very valuable to us. So I'll stop there and hand back to you, Jennifer.
Awesome. Thanks so much, Jonathan. We're super excited about this amazing practice that you have, and we've been listening closely at HEC to all the interviews you're doing on CBC and, you know, the presentations you're doing with Health Canada and other organizations from across Canada. So definitely wish you continued success and really hope to see you as a participant in this program. Just to kind of add to some of the benefits that Jonathan mentioned in terms of, you know, that real ability to network, even informally with peers from across Canada, is also, for example, just in discussions with some interested applicants, you know, if there's not, or if there's a gap for evaluation, for example, that's something that HEC can help you fill potentially if that works for you. Another thing that we've heard in connecting with teams is, you know, a real desire to partner with different communities that the organization provides care for, including First Nations, Inuit, Métis. How is it that you can go about identifying those partners and working with and alongside them to identify needs and really to make sure that the practice that you're going to implement is going to meet the needs and respond to the needs and have the impacts that your communities want to see? Those are all things that we're happy to talk through with you. And you'll see in the application that we do ask really specifically, given this practice that you're going to focus on in this initiative, how can HEC help? We know you do this work every day. This improvement work is part of your day-to-day job, but what is it that HEC can help you do through this kind of all teach, all learn program? So definitely really interested to hear about it. And as I keep mentioning, keep the emails coming, and we're happy to talk through different options where you're going to get applications with multi-sites that really are going to be able to reach a lot of people and form new and strengthen partnerships that already exist. So that was a really long thank you and additional remarks, Jonathan, to what you said, but thanks again for your participation. And thanks also to Judy, who works closely with Jonathan, for your help and support in all of this as well. So that's all for me for today. I'm going to have a look at the chat right now, but I will hand it over to Colleen again to close us out. And Colleen's going to talk a little bit about another program opportunity that may be of interest to a lot of you. So bye from me for now, and over to you, Colleen.
Thanks so much, Jen. And thank you for everyone today. What an enriching discussion we have. Appreciate all the questions we've got coming in from our advisory, some of our promising practices, the shared learning, just quite a rich discussion. So really do want to thank everybody for joining us today. And as Jen said, did want to share a bit about one of our other programs that Healthcare Excellence Canada is looking at. And this is called Innovation, the Health Workforce Innovation Challenge. And really what this is whether teams are accelerating existing initiatives or launching new ones. This challenge provides a low barrier entry, exciting opportunities for monetary awards, and community networking and knowledge sharing. Registration is simple and can be completed in under 10 minutes by providing basic information such as the team lead, organization, contact information, and a retention theme of focus for the initiative. So what we are doing, it is for all types of publicly funded healthcare teams in Canada, really trying those new approaches or models of care to improve staff retention and support. And we do have a focus stream for northern, rural, and remote. And from previous clarifications, that includes the OR. So for more information, please reach out to the email on this slide, and we'll also share that team's email in the chat as well, in case that might be of interest. So once again, thank you so much for joining us today and for allowing us to share this exciting new opportunity with you that would not be possible without the expertise of those on our advisory group and broader. And please reach out via the contact information on the screen. We will also follow up, as mentioned, with any responding to any outstanding questions from the chat, and also share today's information with everyone. Thank you very much. Merci.